Speaker is Professor Urmil Chawla, and she'll be speaking on upper eyelid retraction, causes and management. Over to you, ma'am.
Good afternoon, everybody. After a wonderful discussion of a drooping eyelid, let's now come to the opposite of it, and that's the elevation of the eyelid, and both are cosmetic problems, so the patient is not satisfied with either of them, so he wants a correction. Lid retraction, as you know, it is less common in clinics compared to ptosis, and the surgery is also less defined in terms of surgical landmarks and the amount of recession. Outcomes are also less predictable. Hence, it definitely makes it an important topic to be discussed. The upper eyelid, as you know, it rests around 1 to 2 mm below the limbus, and it can be a mild upper lid retraction or it can be a severe upper lid retraction, as you can see in the upper and the lower. So it is not necessary that every time you will have a scleral show present. Without scleral show also, you can label as a lid retraction. Now coming to the causes, as my topic is, the commonest cause is thyroid eye disease, and it is seen in clinical practice quite commonly. The causes being increased circulating catecholamines, the overaction of the SR-LPS complex, and maybe due to inflammation and scarring. The typical finding of TED which separates it from other lid retraction is the lateral flare, and that is, as you know, that in thyroid eye disease there's an abnormal lid contour and the flare is more, the widening is more, retraction of the lid is more laterally, and that gives the look of the lateral flare. Then there can be congenital causes. It is generally, in this kind, it is generally stationary. It neither increases nor decreases. Neurological causes may be there, and developmental abnormalities can also lead to congenital ptosis, and we need to differentiate it from various other causes of aberrant innervation of third cranial nerve, Marcus gun, jaw winking commonly, or the facial nerve palsy also. Then lid retraction can also be due to posterior lamellar shortening, due to chemical injuries or due to SJ syndrome, where whenever it pulls the lid up with an entropion, then it may lead to lid retraction. Then anterior lamellar shortening, similarly in cases of microblephron or due to trauma, these patients can also have a lid retraction. Post surgery, very common, as we discussed, it's a complication of ptosis, under and over correction both. And also while doing squint surgery, as we know that when horizontal muscles are touched, there may be widening of the horizontal palpebral fissure, and when vertical muscles are operated upon, sometimes there can be widening of the vertical palpebral aperture, and that leads to the lid retraction. It has also been observed in operations of orbitotomy for doing superior orbital lesions. Proptosis can again be another cause of mechanical eyelid retraction, where the eyelid is not the cause over here, it is the globe. The globe is proptosed, and that makes the lid elevated. Further, facial nerve palsy is another common cause. You have to be careful about it, that whenever you see a case of facial nerve palsy, you may sometimes find lid retraction also. Pseudo retraction most commonly seen in cases where ptosis is there, where Herring's law is sometimes quite active. You will see that when we, due to the Herring's law, equal innervation is going to the other eye, while the ptotic eye, the patient is using much power to elevate it, and that leads to retraction of the other eye. And when we elevate the ptotic eye, the lid will droop down. So this is very clinical finding, you can see in clinically also yourself. Now, what are the clinical features of lid retraction? It can be ocular discomfort, foreign body sensation, photophobia, epiphora, lag of thalamus, and most common complication which functionally we have to treat eyelid retraction is because of the fear of exposure keratitis. Besides the cosmetic, this is the most important functional aspect. So before we start with the treatment, we ought to know about the grading, and that is by like subtracting the MRD1 of both the eyes. So mild will be when it is less than 2 millimeters, moderate and severe accordingly. Management, it's not necessary that every time you have to jump to surgery. First go for the conservative management. If there is no patient compliance is good, there is no Bell's phenomena is good, there is less doubt of exposure keratitis, you can go with the routine lubricating eye drops. Then treat the underlying etiology if it is present. If you can find the etiology, like scarring is there, anterior lamellar or posterior lamellar shortening is the reason, or it is after facial nerve palsy, whatever the reason is, treat that, protect the cornea in the meantime. Then botulinum toxin is another good tool that we have, and then finally surgical treatment. While managing the thyroid eye disease, you have to be careful whether it is active or inactive, because the management will vary. In active disease, you will not go ahead with surgical management, you have to go ahead with the conservative management. And also in facial nerve palsy, if it is a recent onset, we need to wait for a period of 3 to 4 months. Then there are temporary procedures, botulinum toxin, which is generally used for the upper eyelid retraction commonly, and it is effective in the inactive TED. But ptosis and diplopia always remain a fear. Then hyaluronic acid gel, it can be used for both upper and lower eyelid, and it can also be used in active TED. While the TCA, it can be generally used for upper eyelid, and the difference between is that best results are seen with the hyaluronic acid gel. The timing is 6 to 12 months, followed by botulinum, and then with TCA. So this is a Botox injection. We generally it can be given transcutaneous as well as transconjunctival, but I prefer the transconjunctival in such cases because sometimes it gives you better results. Then this is if you have an anterior lamellar shortening leading to fibrotic band is there, go for these intralesional injections. They give immediate relief to the patient. Functionally, the patient after first injection will come and tell you that the stretch effect has gone and he feels the softening effect. And in mild cases, I have not needed to do surgery and they have given good results. It is only in later cases, if severe cases, that skin grafting may be needed along with this injections. Surgically, if we need to correct, as I said, the cause of it, and levator surgery in this, we'll do the opposite of what we do in ptosis. So we'll do a recession of the molars or the recession of the LPS muscle. This was one case of post-trauma where after scar modulation, I had to do a FTSG also. Post-surgery, if it is due to overcorrection after LPS resection for ptosis, then first go for conservative management. Don't jump to take the OT patient again to the OT next very day. Sometimes conservative management also helps you. Give traction sutures, lid massage and squeezing exercises, and finally if it doesn't, then go ahead with the redoing of the procedure, or sometimes may land up with doing a recession of LPS. Coming to the levator surgeries, we can do Z myotomy, tenotomy, retractor recession. However, they can have unpredictable corrections, and as we know, measuring of the recessed part is not very, we don't have any algorithms for that. For mild, you can go for a tenotomy where you give a full thickness incision through the molars as well as the LPS aponeurosis, and you can get this good result in this. Not showing the video. Moderate eyelid retraction, the levator recession, in this case I had done a levator recession. The most important point in recession surgeries is the traction suture. The traction suture needs to be kept for at least 5 to 6 weeks. That is where the compliance of the patient has to be checked, and where sometimes, because I had one case like in this particular case, at 1 week he was okay. At 3 weeks, if you can see, he started retracting because he broke his suture and did not come for follow-up. I just scolded him, and again I applied the suture at this was 3 weeks, then again, and lastly we could get some good results after giving the traction sutures again. So traction sutures are very important, because after doing recession, sometimes the lid again, initially on first day you will see it normally, but again it goes above, retracts again. So please be careful. The traction sutures are very important for 6 weeks at least. Then this I have not tried. Please. This is theoretical levator recession with spacer.
Please sum up, ma'am.
Yeah, vicryl mesh, silicone, sclera, temporalis fascia, all these things can be done. Drawbacks of this surgery are inherent unpredictability, frost suture, as I said, 6 weeks, and spacer related issues may be there. So my take home message is to identify the cause, grade the retraction, choose appropriate surgery, ensure patient compliance, and counsel the patient about the unpredictable results. And how much to recess? Recession can be taken as double the amount of retraction. If 2 mm retraction is there, you either bring it from the original position to the 4 mm position, or 2 mm below the limbus. And position of the lid on the table is very important. It should be lower than normal position by an amount equal to the retraction. So thank you very much. Sorry I have not been able to show the video, because today morning my video just stopped working. It already showed in DOS.
All right. So it was a nice presentation, very elaborative. I have 1 or 2 questions to ask. One is about the intralesional triamcinolone. Like, what is your regime for it? And do you repeat it? If you repeat it, then at what interval you repeat it, and at what like position or place you give it in the lid?
So initially I did a thesis on only 5-FU injections when I started, and 5-FU we used to give intralesionally in periorbital scars. I had done the thesis. So periorbital scar ke around 1 cc you give it. Reconstitution you have to remember it, 0.9:1 ratio may we reconstitute it, and we repeated the injections at an interval of 4 weeks. So generally after 1 week only or second visit, the patient used to feel very comfortable because the stretch effect is gone, and he himself comes to say कि मेरे को अच्छा लग रहा है, तो and he's agreeing to for the other injections also. Very mild cases, sir, I could go with 5-FU only, जिनमें बहुत mild periorbital scarring की वजह से retraction हो रही है या कुछ cosmetic anomaly है, वो भी ठीक हुई. But otherwise, after the last injection, 4 weeks after the last injection, we did FTSC in such cases. Then second time I added my thesis with 5-FU plus TCA, and we did a comparative study, and the results were slightly better. No, I won't say very significantly, but they were better with 5-FU plus TCA. So nowadays we are, in our place, we are giving 5-FU TCA.
No, but where do you give? Like,
Sir,
it's not in the
entire
scar.
periorbital scar, subcutaneous.
No, it's not in the scar cases. Like, I am asking about the typical lid retraction, which is there without the cicatrization.
Okay.
Like in thyroid eye disease cases or.
So thyroid eye disease I am
okay.
not giving, I am only giving in cicatricial cases.
Yeah,
Yeah,
that's
thyroid
triamcinolone.
eye.
That's
Yeah.
triamcinolone. So, like, what is done is basically in a supratarsal plane,
Yeah.
we inject it and we repeat it, say after 3 to 4 weeks. Generally, 2 doses are around 1.5 to 2 millimeter of retraction. So that's a fair thing to go for a initial treatment basically. But only thing is you have to monitor IOP. In some of the cases, patients do get IOP rise. So
Have you ever noticed any skin thinning when you are using 5-FU,
No.
especially along with the
No,
triamcinolone?
no. Only one case we had some hematoma kind of thing, but otherwise we have never observed any
Thinning or
skin.
ulcerations?
No,
you have
nothing, no side effects. Yes, patient can sometimes on the day of injection can have fever sometimes. So we advise him, if you have fever, you take sometimes. Otherwise not. But there is no side effect other than
and in severe cases, we do have to resort to spacer.
Yeah.
Eye bank sclera is a very good thing if you can get it. So that is supplemented a strip of that in the tarsus so that a lengthening of lid occurs. Yeah.
Ma'am, in case of 5-FU, do you dilute it with xylocaine or not? Because it's a pretty painful injection, what I've noticed.
initially we dilute with saline, but when we inject it, first we inject xylocaine and then the
Okay,
reconstituted.
2 separate needles
Yeah.
you are trying
You
to
can-
say?
Yeah. two
And
separate.
one more thing, like in cases where you are expecting certain amount of post-operative scarring, for instance,
Yeah.
in revision surgeries and all, and you want to start 5-FU, how long would you want to wait before starting 5-FU? As in a fresh case of trauma or a post-operative case has come to you in which you are expecting certain amount of scarring, and you know you might need to give 5-FU down the lane. When would you like to start the 5-FU injection?
See, in cases of trauma also, sometimes when fresh trauma comes, I never start immediately. When the area is raw, when you feel that the skin has not healed, erythema is there, and sometimes infection also if you feel, I never start it. I wait for it because scarring is going to happen, and if you give a little bit late, effects will be good. But if you go in the infected state, then it will not be good. I have not tried and I don't give. At least
Okay.
I wait for 1 to 2 weeks when the healing is proper, then only I start first. In surgical cases, I have not like on table or later on only. If I find that fibrotic band is forming, then only I would
Yeah.
go. You feel it,
Yeah.
palpate it. If you feel that band is there or you feel that scarring, not in every case that you
Not
will
in
go
every
ahead.
case. I meant like in such cases as all those revision surgeries who've already been operated like 2-3 times. You're going
Yeah,
ahead
you can
with
go ahead if
reconstructions.
the surgery. I think 3 to 4 weeks after
3
surgery
to 4
should be
weeks.
safe.
Yeah. Thank you.
So I think